So hi everyone, today we will be talking about our project, which is to design an early mobilization intervention package for nurses at the Jewish General Hospital. To start off, I would need to introduce some relevant background information. So the first thing I'll be talking about is hospital-acquired disability. It occurs when a patient, usually of older age, who is admitted to the hospital, leaves with a decreased ability to perform activities of daily living. In addition, it has been well established that early mobilization and patient mobility is a very important component in improving patients' recovery, their health outcomes, and allowing for earlier discharges. As such, patient mobility has a big role in preventing and reducing hospital-acquired disability. However, it is common to find patients spending most of their time in bed and relying on others to help them perform their activities of daily living. The current culture does not promote mobility, and this shows when approximately 30% of older patients encounter hospital-acquired disability. As such, our overall objective is to develop an early mobilization intervention package for nurses at the hospital setting in order to promote mobility, and it is divided into two phases, which is Emily will talk about in further detail.
So the methods of our project are best viewed through this flow diagram. And as you can see, phase one is the comprehensive literature reviews. We did two different searches, one for the barriers and facilitators of nurses performing early mobilization. And the second one are best practices for knowledge dissemination. So essentially how best to teach nurses this intervention protocol. And so they were searched, screened, and extracted. And then phase two is the more complex phase of mapping components. So we took the barriers from the literature review and we mapped them to the CFIRE constructs. And from the CFIRE constructs, we used a matching tool to map them to the appropriate implementation strategies. And we used the ERIC implementation strategies. And from there, screened all of them using the APPEASE criteria to find out if they would be best suitable and most feasible in our setting. And once we had the final implementation strategy screened, we used the tidier framework to develop the who, what, when, where, why of the educational component and our total package. So in terms of results for phase one of the comprehensive literature reviews, the first search, the barriers and facilitators, the search yielded 432 articles and only 26 were included for extraction. And the top barriers perceived by nurses were either organizational and institutional, such as lack of staffing, lack of time, lack of equipment, or more related to education skills. So their lack of confidence and self-efficacy towards that. And then the best practices for knowledge dissemination. Search yielded 75 articles, only 6 were included for extraction. They yielded 18 modes of delivery, which were identified as either practical, hands-on, or more passive. So one-on-one coaching versus like a PowerPoint presentation. And within those 18 modes of delivery, 14 topics were identified on what they were actually taught. And that included mobilization guidelines and protocols, benefits and risks, and the actual techniques of the mobilization.
All right, so now we're going to look a little bit at the results and discussion for phase two, so the mapping components. So as Emily said, there was 49 perceived barriers that were identified from the literature across both acute care settings, so similar to what we will be intervening in, or the ICU. The nurse perceived barriers were not commonly related to were most commonly related to access to knowledge and information, available resources, compatibility with the implementation climate, networks and communication, and patient needs and resources. So these were then classified to the CFIRE constructs, in which there were 14 that were found, as you can see on the screen. They were grouped into 5 different categories, and from there they were mapped to the ERIC. So those 14 constructs of the CFIRE then became 57 strategies from the ERIC, targeting a variety of things, looking at education, knowledge, skills, and behaviors. And these were all components that are going to be included in the intervention package at the end. We then looked at the APPEASE criteria. So all of these 57 strategies from the ERIC went through multiple rounds of the APPEASE and were grouped into 9 strategies. So some of these are conducting educational meetings, develop and distribute educational materials, conducting ongoing training, et cetera, et cetera. So all these strategies are really to promote the adoption of the intervention package into the clinical setting at the end of the day. So lastly, we looked at the tidier framework. So going from appease to tidier. This is, as Emily said, where we look at the who, what, when, where, why. And this is really where we get a blueprint of the intervention and how things are actually going to be delivered. So let's look at that table a little bit more. I'm just going to highlight one of the intervention strategies. So conducting ongoing training. So essentially, who is that being delivered to? It's the educational nurses. So that's the parties involved. How is this going to be done? Bedside teaching, face-to-face training, one-on-one coaching. Basically, the rationale for this is that you need to train every new nurse that comes onto the floor so that the intervention can continue even past those nurses leaving. So when it's implemented, it's variable, depends when there's a nurse turnover. So we just want to ensure that everyone's getting that same intervention.
So for the limitations, the first one is that barriers associated with a lack of resources were not addressed, such as lack of staff, lack of space, equipment, and time. Next one is that the articles in the literature review did not specify which mode of delivery is the most effective. However, we use different frameworks to identify the most appropriate and feasible for a setting. Then the intervention package still needs to be validated with the team at the Jewish General Hospital. So because of the COVID situation, we had less frequent meetings with them. So now that our project is done, the next steps are to validate the intervention package with the team, to create the content that's going to be taught to the nurses, and to implement all the intervention strategies that were shown in the previous table. So to conclude, the final product of this project is a multi-component intervention package that targets both education and skill development. We hope that this study can serve as a template to implementing early mobilization programs, because we know that those early mobilization programs can have a significant impact on patient outcomes and potentially reduce the burden on the healthcare system in the long term. Thank you.